Assalamu alaikum. In the last video, we talked about the pathophysiology of ACS. Please keep in mind that the rupture of plaque and not only the plaque formation is involved in the pathophysiology of ACS. Plaque rupture and intracoronary thrombus formation is an acute process that occurs within minutes to hours. The formation of plaque is a chronic process that takes time, that takes up to months and years to develop. And even after the development of plaque, uh, it's possible that the patient don't experience any symptoms of angina because initially the plaque is small and it develops slowly. So after the development of plaque, if it occludes more than 70% of the diameter of the lumen, the patient would start experiencing angina when the myocardial oxygen demand of the heart increases. So for example, if the patient is exercising or he is climbing some mountain, or for example he is using stairs, so in those cases the myocardial oxygen demand would increase and the patient would experience angina. So the angina in that case is predictable. We can predict when the patient would experience angina. So that condition is of stable angina. That is not an acute condition. That is a chronic condition and we treat it separately. ACS or acute coronary syndrome, that happens when the plaque ruptures and intracoronary thrombus formation is developed. So I hope you are clear about this. So let's compare what are the characteristics of these different conditions, what are the type of ACS. So looking at this is the condition of stable angina. You can see a plaque is formed in the artery, but the plaque is not occluding whole diameter of the artery. So the blood flow is present, the myocardial tissue is perfused, but when myocardial oxygen demand is increased, in the cases when the patient is exercising or using stairs, so in that case the blood flow would be compromised because this part where plaque formation has occurred, this is not able to dilate properly to meet the myocardial oxygen demand. So the patient would experience angina. But it is important to note that there would be no electrical changes in ECG and no troponins, which is a cardiac biomarkers, they would be present in blood. So cardiac biomarkers, they appear in blood when myocardial injury happens. So in stable angina, the patient is experiencing pain due to the ischemia of the tissue, and ischemia is not so prominent that it leads to the injury of the cells. So this stable angina is not included in acute coronary syndrome. This is not an acute condition, it is a chronic condition, and if ischemia happens in these patients, the treatment of ischemia is separate than the patients which are of ACS. When this plaque ruptures, intracoronary thrombus formation occurs, and this intracoronary thrombus formation may occlude the artery partially or completely. So for example, in this case you are looking at a partial occlusion of the artery. So due to partial occlusion of the artery, the myocardial cells, they experience ischemia, and those ischemic changes, they may or may not appear on ECG. So the ECG, that could be normal, that could show inverted T waves or ST depression, and there would be no presence of cardiac biomarkers or troponins in blood. So this condition is called unstable angina. The patient is experiencing angina which was not predictable in that patient. The third case is, you can see that an intracoronary thrombus formation has occurred. It has partially occluded the artery. The cells are experiencing ischemia and some of the cells are also injured as well. So you would see ECG changes. ECG could be normal, there could be inverted T wave or ST depression, and the troponins would be elevated because some of the cells, as you can see here, they are damaged. So this condition is called non-ST elevation myocardial infarction, because myocardial infarction or death of tissue has occurred, but there are no ECG changes of ST elevation. So you can see the ECG could be normal, that could be an inverted T wave or ST depression, but there is no ST elevation present in this case. In this fourth case, a complete occlusion of the artery has occurred, and the cells, they would start dying and they would release a lot of troponin in blood, and you can see that the ECG changes are different. Now ST elevation or hyperacute T waves are present on ECG. So this is a myocardial infarction, but because ST elevation is present, so that's why this type of myocardial infarction is called ST elevation myocardial infarction. So ACS has these three types: unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. So because both in unstable angina and non-ST elevation myocardial infarction, ST elevation is not present. Other changes are may or may not present, but ST elevation is not present. So that's why these two types, unstable angina and non-ST elevation myocardial infarction, are classified as non-ST elevation acute coronary syndrome, or NSTE ACS. So you can, if you know the pathophysiology of all of these conditions, you can predict that the short-term risk of death is very high in STEMI or ST elevation myocardial infarction, and then in non-ST elevation myocardial infarction, and then in unstable angina. So definitely where the short-term risk of death is high, the management of this condition would be different, and where the short-term risk of death is low, the management would be different. So now we will move to the management of ACS. So if there is clinical suspicion of acute coronary syndrome, the first decision the clinician has to make is whether it is a STEMI or non-ST elevation ACS. So that depends on ST elevation. So if there is persistent ST elevation, then it is a STEMI, and if persistent ST elevation is not present, it is a non-ST elevation ACS. Let's see STEMI first, how it is managed. So in STEMI, the risk of short-term death is very high. So that's why initiate reperfusion is required. So reperfusion could be done by two ways, either by mechanical intervention of primary percutaneous coronary intervention, or by using a fibrinolytic. So it is a important decision when to use primary PCI and when to use a fibrinolytic. So you have to see whether primary PCI is possible within 120 minutes. If it is possible, go for PCI. But if it is not possible, go for fibrinolysis by the use of fibrinolytics. So in some hospitals, primary PCI, the facility of primary PCI, or the cath lab, cardiac cath lab is present, so PCI is possible in those hospitals. So in that case, if it is possible within 120 minutes, the patient should undergo PCI. And the goal is that if PCI is possible, it should be performed it should be initiated within 90 minutes of first medical contact. So you should not delay PCI if it is possible in the case of STEMI. But if it is not possible within 120 minutes, then go for fibrinolysis. And the goal is that you should inject fibrinolytics within 30 minutes. So door to needle time should be 30 minutes. It should be your goal. So the 120 minute window is very important to consider, because on the basis of that you have to decide whether the patient would undergo primary PCI or the patient would undergo fibrinolysis. So now let's come on non-ST elevation ACS. Non-ST elevation ACS, we discussed earlier that it has two types: unstable angina and non-ST elevation myocardial infarction, and it depends whether troponins are present or not. So if cardiac biomarkers or troponins that are positive, it is a non-ST elevation MI. So I have missed an E here, it is NSTEMI. And if it is cardiac biomarkers are negative, it is unstable angina. But whether non-STEMI or unstable angina, the management is very similar, and the management depends on the risk. So in this case of non-ST elevation ACS, we have to decide the management of patient based on the short-term risk of death. So we have to see what is the risk of short-term death. If the risk of short-term death is high or intermediate, we will go for early invasive approach. I will talk about this shortly. But if the risk of short-term death is low, we have to go ischemia guided approach. So definitely if the patient has unstable angina only and there are no troponins in blood, definitely the risk of short-term death is low and he would go for ischemia guided approach. But if the patient has positive troponins, as well as, for example, the patient is older, or it is not the first time he has an ischemic event or angina episode, or for example he is diabetic, then definitely the risk of short-term death is high and we can opt for early invasive approach. So there are some ways to calculate the risk of short-term death. So there are some scores which you can calculate for each patient to calculate the risk of short-term death. So for example, TIMI score and GRACE scores, they are used to estimate the risk of short-term death. So in early invasive approach, the initiation of PCI is not as critical as in STEMI. So for example, the patient could wait for an angiography and consideration for PCI. So early invasive approach means the patient would undergo mechanical intervention, but the need of mechanical intervention is not as critical as in STEMI. Ischemia guided approach, that is a fancy name given to the management of patient with the help of drugs only. So no mechanical intervention is involved. We should manage the patient with drugs only. So regardless of whether the patient is of STEMI or non-ST elevation ACS, all patients receive supportive care. So initial supportive care is similar for all patients, no matter whether the patient is of STEMI or of non-ST elevation ACS. And this is the mnemonic for initial supportive care, MONA B. All patients, they receive these initial supportive cares. M is for morphine or other narcotic analgesic. If the pain is refractory, the patient could receive morphine, but the use of morphine or other narcotic analgesics is controversial. Oxygen, the patient, you can give oxygen to patient if saturation is less than 90%, but the benefit of oxygen in patients whose saturation is more than 90% is not established. All patients received nitrates, or for example sublingual nitroglycerin or sublingual either a tablet or spray. All patients receive a single dose of aspirin, and if the patient is allergic from aspirin, that can take clopidogrel. And beta blocker, for example carvedilol and metoprolol. So all patients, they receive this initial supportive care. So regardless of the patient is of STEMI or non-ST elevation ACS, whether the patient is undergoing early invasive approach or ischemia guided approach or primary PCI, all patients of ACS, they receive antithrombotic therapy. And antithrombotic therapy is given to prevent the formation of thrombus. So to prevent the formation of thrombus, even after it is removed by mechanical intervention or fibrinolytic, there are chances of development of thrombus. So to prevent the formation of thrombus, antithrombotic therapy is used. And in antithrombotic therapy, both antiplatelet and anticoagulant therapy are necessary in acute treatment phase of ACS. So in acute phases, for example, when the patient is in hospital, both antiplatelet and anticoagulant is required. But after hospital discharge, only continuous long-term use of antiplatelet therapy is required, and not the anticoagulant therapy in most of the patients, but some high risk patients may also benefit from anticoagulant therapy after the discharge as well. So keep in mind that all patients of ACS they would receive antithrombotic therapy. So we will discuss about the antiplatelets in the next video, that which antiplatelets are required for these patients of ACS, what are their differences, in which condition which one is preferred and which one is not. So stay tuned for the next video.